Welcome back to the ProPA podcast. I'm your host, Prof. G, and this is another episode in our MSK101 Clinical Medicine Brief series, where we break down high-yield topics from the PANCE blueprint, one bite-sized episode at a time. Today's topic is a lesser-known but highly testable vascular disease called Buerger's disease. It's also known as Thromboangiitis Obliterans. It's strongly associated with tobacco use and can lead to serious limb ischemia. Let's dive in. Did you know that Buerger disease is almost exclusively found in young male smokers under the age of 45? It is so closely tied to smoking that quitting tobacco is the only effective treatment. The disease was first described in 1908 by Leo Buerger, who was an Austrian-American pathologist. Speaking of pathology, let's look at the kinder patho. So what is Buerger disease? It is a non-atherosclerotic segmental inflammatory disease of small and medium-sized arteries and veins, primarily affecting the hands and feet. It leads to vascular occlusion, tissue ischemia, and in severe cases, ulceration or even gangrene. The cause isn't fully understood, but it is strongly linked to tobacco use, including cigarettes, chewing tobacco, and even vaping products. Inflammation causes thrombosis of blood vessels, but unlike atherosclerosis, the internal elastic lamina is preserved. There's also vein and nerve involvement, which helps differentiate it from other forms of peripheral artery disease. Okay, so how do these patients present? Well, patients with Buerger disease typically present with claudication of the hands or the feet, rest pain in distal extremities, ischemic ulcers or digital gangrene, Raynaud phenomenon, and superficial thrombophlebitis. And remember, it often affects young males under the age of 45 who are heavy tobacco users. All right, workup and diagnosis. So, diagnosis is primarily clinical and it's supported by a history of tobacco use, distal extremity ischemia, and exclusion of other causes like atherosclerosis or embolic disease. An angiography may show segmental occlusion, corkscrew collaterals, which are tortuous vessels formed due to chronic ischemia, and the absence of atherosclerotic plaques. There are no specific lab markers for Buerger disease. Rule out autoimmune or hypocoagulable conditions. Treatment. The cornerstone of treatment is complete and permanent tobacco cessation. This is including cigarettes, vaping, and chewing tobacco. Other interventions can include supportive care like wound care and pain management. We can prescribe calcium channel blockers or vasodilators for the Raynaud symptoms. Iloprost is a prostaglandin analog and it may help with pain and ulcers. And amputation may be required in severe cases. It's important to note that no medications are effective unless the patient stops smoking tobacco. All right, bookmed versus treatment. So, bookmed, a young male smoker with foot pain, ulcers, and Raynaud symptoms. You'll recognize those buzzwords when you see them. Street med, patient says, Doc, I'm getting this weird pain in my foot when I walk, and my fingers keep turning white when it's cold. You check the chart, he's 37, smokes a pack a day, and he has a shallow ulcer on his toe. If you're not thinking about Buerger disease, you might miss this diagnosis. All right, let's do some quick clinical pearls. So, strongly associated with smoking in young males, it affects small to medium arteries and veins, primarily in the extremities. You're going to want to look for Raynaud phenomenon, digital ulcers, and superficial thrombophlebitis. Angiography can show those corkscrew collaterals, and smoking cessation is the only effective treatment. Consider it in a young smoker with ischemic extremity symptoms. All right, now it's time to hit the PANCE practice questions. So, question 1, a 34-year-old man presents with toe pain, discoloration, and a shallow ulcer on the tip of his great toe. He has a 15-year history of smoking. Angiography reveals segmental occlusions and tortuous collaterals. What is the most appropriate next step in management? Is it A, start aspirin and clopidogrel? B, refer for bypass surgery? C, smoking cessation? Or D, begin high-dose corticosteroids? I'll give you a few seconds. If you said C, smoking cessation, you have been paying attention. Great job. So, complete tobacco cessation is the only proven effective treatment. Which of the following is not typical in Buerger disease? A. Superficial thrombophlebitis, B. Claudication, C. Atherosclerotic plaques, or D. Raynaud phenomenon. All right, if you said C, atherosclerotic plaques, you are correct. So, Buerger disease is a non atherosclerotic inflammatory condition. So, some final thoughts. Buerger disease is a classic PANCE topic that's easy to recognize if you're looking for it. Just remember, young smoker, distal extremity ischemia equals Buerger disease. And if they don't quit smoking, there's no treatment out there that'll help them. Found this episode helpful? Don't forget to follow the Pro PA podcast and visit my YouTube channel, Professor GPAC, for more clinical briefs, exam tips, and PA student content. And hit that bell so you never miss a drop. Thanks for listening to this clinical medicine brief of our MSK101 series. And remember, this is the Pro PA podcast, where future pros in medicine are made. Until next time, keep on learning.